Good afternoon to everyone. We would like to start our section dedicated to the acute pancreatitis poster section. And I would like to invite Professor Stefan Krystowski to switch on the video, and rest participants to turn off video and mute. По можливості виключити відео ті, хто поки що не доповідають. And we are waiting for Stefan.
Yes. Do you listen me?
Yeah, but please switch on the video.
Start my video.
Okay. Yes. Nice.
It's okay now?
Yes. Nice to meet you.
Nice to meet you.
Okay, we're going to start. And if you let me, I will introduce the first work.
Okay.
Is calling the SIRS COVID-2 infection is associated with increased risk of idiopathic acute pancreatitis, but not pancreatic exocrine insufficiency or diabetes. Long-term result of COVID-PAN study, presented by Chris Varghese and other co-author, as I understand, from New Zealand and Great Britain.
Hi, my name is Chris Varghese and I'm a trainee intern at Auckland, New Zealand. Today I'm presenting results of the one-year follow-up of the COVID-PAN study. The original COVID-PAN study found a high rate of patients with concomitant SARS-CoV-2 infection and acute pancreatitis had poorer outcomes. Notably, a quarter of these patients were considered to have idiopathic etiology to their pancreatitis. This raised the question of whether SARS-CoV-2 can cause acute pancreatitis like other viruses. We therefore aim to investigate the final etiology of these patients after appropriate investigations and the long-term one-year outcomes. We've performed a prospective international cohort study of consecutive patients with acute pancreatitis. Multi-level, multivariable logistic regressions were used to assess outcomes. 1,476 patients had complete 12-month follow-up data. Of these, 101 patients had concomitant acute pancreatitis and SARS-CoV-2 infection. Idiopathic etiology was found in 35% of those with concomitant infection, compared to only 14% of those with acute pancreatitis alone. This difference was statistically significant and persisted after multi-level, multivariable adjustment for age, smoking status, BMI, and ethnicity. Concomitant infection was associated with a 5-fold increase odds of having an idiopathic etiology. These analyses also found that concomitant infection was not associated with long-term mortality, diabetes mellitus, or pancreatic exocrine dysfunction at 1 year. This study provides population-level evidence supporting the etiological role of SARS-CoV-2 infection and acute pancreatitis, perhaps through viral replication within pancreatic cells and resultant cell injury. More laboratory-based and mechanistic research is required to further elucidate the causal relationship. particularly in the context of a potential COVID endemic?
Thank you for your nice presentation. Are you present here?
Yes, next.
No, I have one question, if it's possible. Would you answer us how many patients in groups with COVID infection have severe and moderate severe pancreatitis, and what kind of complication have you observed in them? Thank you.
Hi, that's a very nice question. We had roughly 10% of the patients in the COVID positive arm with severe pancreatitis and about 18% with moderate to severe pancreatitis. We hypothesized that because of the viral replication in the pancreatic cells that they might be at increased risk of diabetes and exocrine insufficiency, and so particularly focused this analysis on those outcomes. We also looked at mortality, but found that at 12 months, they weren't significantly different to those with acute pancreatitis without SARS infection. We also looked at outcomes at the time of infections like ARDS and things like that, which was reported in the original study. And so it appears that the acute outcomes are a lot more worse than the long-term outcomes at the 1 year time point.
Very nice. Thank you for your nice presentation. Thank you.
Next presentation, results of treatment fluid collection in acute pancreatitis using minimal invasive procedure.
I think that the presenter cannot connect. Maybe we can switch on the video of the recording.
We can go with
going forward.
Strategy of surgical intervention in patients with complicated acute necrotizing pancreatitis. Good afternoon. You can start with your presentation.
Yes.
Dear colleagues, I am glad to present our abstract on surgical treatment strategies of acute necrotizing pancreatitis. Despite progress in the diagnostic, conservative, and surgical treatment, mortality in severe forms of acute necrotizing pancreatitis remains high and range from 5 to 13%. At the same time, the ideas concerning the place, role, and methods of surgical procedure in acute necrotizing pancreatitis are significantly different. There is no single point of view concerning the indication for the use of minimally invasive methods of treatment and laparoscopic necrosectomy, depending on the terms of the disease, extension, nature, and localization of the pathological foci. Objective of our research was to establish efficacy of proposed minimal invasive approach for treatment of complicated acute necrotizing pancreatitis. The analysis of the treatment results of 383 patients with acute necrotizing pancreatitis who underwent treatment with application of the step-up approach during 2016-2020 years was performed. Acute pancreatitis was defined according to the 2012 revision of the Atlanta classification. Step-up minimally invasive approach was applied to patients with acute necrotic collection and liquefactive wallet of pancreatic necrosis, whereas in cases of solid wallet of pancreatic necrosis, we prefer one-step necrosectomy technique. For each episode, we collected following data length of hospital stay, mortality, new organ failure, and local complications. Transcutaneous interventions were applied as the first step in 87 patients with acute necrotic collection. In the presence of liquefactive wallet of pancreatic necrosis and ultrasound procedures, we are preferred in case there close localization to the stomach or duodenum in 135 observations. Initial surgical treatment wasn't effective in 19.8%, and video-assisted retroperitoneal debridement in patients with acute necrotic collection or necrosectomy under and the ultrasound control were necessary. One-step necrosectomy was applied in 14.5% of patients. During postoperative period, complications occurred in 27.3% of patients. They included 40 new episodes of organ failure, 13 cases of erosive hemorrhage, and 15 observations of pancreatic and duodenal fistulas. Our mortality rate was 3.3%. After surgical treatment, 6.5%. Interventional treatment of patients with acute necrotizing pancreatitis based on our step-up approach is followed by acceptable complication and mortality level. Combination of step-up and one-step approach, independence of morphology of necrotic collection, is effective strategy or surgical treatment of complicated acute necrotizing pancreatitis. Thank you for your attention.
I have a question to Professor Khomyak. May I? Research? Well, just one question. Hello? I would like to ask, what exact indication do you think is necessary for one-step approach could be applied in a patient with acute necrotizing pancreatitis?
Thank you for your nice question. We apply one-step approach to patient with a large volume of pancreatic necrosis and the presence of sequesters. Our experience show that such patients minimally invasive necrosectomy could not give a successful cleansing of necrotic tissue. Therefore, several repeated minimally invasive interventions are usually required, and finally, most patients require open surgery.
Okay, thank you. Thank you very much. So if we go forward, the next presentation from Ukraine is comparison of presepsin and procalcitonin for prognosis of infection complication of acute necrotizing pancreatitis, presented by Alexandra Grama. Good day. I would like to represent our report entitled Comparison of Presepsin and Procalcitonin for Prognosis of Infection Complication of Acute Necrotizing Pancreatitis. Early determination of patients with acute necrotizing pancreatitis with high risk for infection complication is crucial for their effective treatment. Several markers were established for the early diagnosis, and presepsin and procalcitonin were the most promised. Purpose of our study was to compare utility of presepsin and procalcitonin for prognosis of infected complication development in patients with acute necrotizing pancreatitis. Prospective study of 115 patients with suspected infected acute necrotizing pancreatitis has been performed. Level of presepsin and procalcitonin in patients with systemic inflammatory response syndrome lasted longer than 1 week, was estimated every third, 5th day until invasive treatment was applied. Bacteriological investigation of acquired materials served as criteria for diagnosis of infected necrotic collection. Bacteriological investigation confirmed infection presence in 69.5%. The rate of presepsin was significantly high on the patient with infected complications, with cutoff level about 632 picogram per milliliter at the time of invasive procedure, 457 picogram milliliter within a week before decision of its application, and 403 picogram milliliter in case of prolonged system inflammatory response syndrome. Procalcitonin level reached 203 nanogram milliliter in person with confirmed infectious complication at the time of invasive procedure, but failed to reach significant changes in early period. So we made conclusions that presepsin is a promising prognostic marker of infectious complication with patients with acute pancreatitis, whereas procalcitonin has low prognostic utility. Thank you. Thank you very much. There is a question to Alexander Grama. There are many different biomarkers of presence of different septic complication. What about the possible prognostic biomarkers which we can use to prognose the development of possible infection complication? Please.
Thank you for such a good question. Besides procalcitonin and preseptin C, reactive protein, interleukin-6, endotoxin, and receptors for it were evaluated as possible prognostic markers of infected complications. We are currently performing such study, but we are not ready to make conclusions still, as all data is not calculated. Thank you.
We are waiting for your results. Thank you.
Thank you.
Okay. Okay, we're going further. So next topic, next presentation, which we're going to listen is a post-discharge mortality is overlooked outcome measures in acute pancreatitis, a prospective international cohort analysis of 3,237 patients, presented by Dora Chapari
Good afternoon.
Hungary. Okay, you're welcome.
Dear audience, my name is Dora Sapari, and I am a PhD student at the Institute for Translational Medicine, University of Pécs, Hungary. I am grateful for the opportunity to give a brief overview of our research, where our aim was to investigate the post-discharge mortality as a so far overlooked yet potentially useful outcome measure in acute pancreatitis. We used the database of the acute pancreatitis registry run by the Hungarian Pancreatic Study Group. Anamnestic admission details and outcomes were registered, and survival data were collected within the 8-year follow-up period. A total of 2,613 cases were analyzed. We found that the mortality rate was still high in the first 3 months after discharge, almost reaching the mortality rate during the inpatient period. Among anamnestic parameters, we also found that age, body mass index, comorbidities, and diabetes showed association with shorter survival in the 12-month follow-up period. We also examined admissions parameters as predictors and found that all renal laboratory biomarkers, C-reactive protein, hematocrit, hemoglobin, glucose, and pleural fluid had a significant negative effect on 12-month survival. Examining outcome parameters, severity, and both local complications and organ failure are strongly associated with shorter survival within 12 months after discharge. Most importantly, almost as many patients died in the first 3 months after discharge as during the hospital stay. It is essential to review the follow-up time of people with EP and to continue to include them in post-discharge follow-up. We identified several factors associated with shorter survival. However, further analysis is needed on the causes of death. Thank you for your attention.
Dora, thank you for your nice presentation. I would like to ask you one question.
Yes.
What were the most frequent? Okay, Stefan, I'm asking question. If
Okay,
you
okay,
let me. Okay. What were the most frequent causes of the death in this early post-discharge period in these patients?
The most frequent cause was depend on the time of the death. In the first 3 months was the most important cause, the cardiac failure. And that's why our suggestion is the doctors pay a lot of attention patients with cardiac diseases.
Okay. Okay, thank you.
Okay. We can go with the next presentation, which is correlation between abdominal perfusion pressure and timing of infection of pancreatic necrosis in patient with acute severe pancreatitis.
Hello, dear colleagues. The topic of presentation is correlation between abdominal perfusion pressure and timing of infection of pancreatic necrosis in patients with acute severe pancreatitis. My name is Ivana Shehil. I am one of 4 authors of this study, and now I present it. I work in Bogomolets National Medical University in General Surgery #1 department. We don't have any relevant financial relationship to disclose. Our purpose was to study the relationship of abdominal perfusion pressure in the first week of the disease, timing of infection of pancreatic necrosis in patients with acute severe pancreatitis. Our methods. In all patients with acute severe pancreatitis, the level of abdominal perfusion pressure minimum was assessed in the first week of the disease as the difference between mean arterial pressure and intra-abdominal pressure. All patients had infectious complication of acute necrotizing pancreatitis. Positive bacteriological culture of aspirate of acute liquid parapancreatic accumulation registered for the first time corresponded to the period of onset of pancreatic necrosis infection. Correlation analysis between abdominal perfusion pressure minimum in the first week of disease and the period of infection of pancreatic necrosis was conducted by Spearman's rank correlation coefficient. Materials. We studied the data of 74 patients with acute severe pancreatitis. The age median was 47 years. 51% of patients were men and 49 women. Intra-abdominal pressure median was 12. Mean arterial pressure median was 74.5 and median abdominal perfusion pressure minimum was 62. Median onset of infection was 11 days and mortality was 34%. As a result, a strong positive correlation was found between the abdominal perfusion pressure minimum during the first week of the disease and the timing of infection in patients with acute severe pancreatitis, as you see. Conclusions. A strong positive correlation between the level of abdominal perfusion pressure in the first week of acute pancreatitis and the timing of infection of pancreatic necrosis indicates the influence of perfusion disorders in the early phase of the disease on the timing of infection pancreatic necrosis. Thank you for your attention.
Thank you very much for your nice presentation. I would like to raise one question to you. May I? What technique did you apply to estimate intra-abdominal pressure?
Classical indirect method by gallbladder. Yeah.
Okay. Have you found any difference between impact of intra-abdominal hypertension and depleted intra-abdominal perfusion pressure? Is there any difference or they have similar impact?
Can you repeat your question, please?
Have you found any difference between influence of the intra-abdominal hypertension and decreased perfusion pressure to the patient outcome?
Yes, that's the main. Like our previous study was connected only to the intra-abdominal pressure, but then we started to use then in cardiological insufficiency, so mean arterial pressure and abdominal perfusion pressure to find outcomes. Thank you.
Okay, we can go to the next presentation, which comes from United Kingdom. polymorphism of the tumor necrosis factor alpha gene, and the severity of acute pancreatitis, a systematic review and meta-analysis.
Hi, my name is Wing. I'm one of the medical students from Norwich Medical School in the UK. Today I'm presenting polymorphisms of the tumor necrosis factor alpha gene and its relationship or potential relationship with severe acute pancreatitis. So a quick disclosure, I've received some funding from the Wolfson Foundation as well as the Royal College of Physicians. As a background, acute pancreatitis has a very vast spectrum of clinical presentation, from most cases being mild, but a subset of patients developing severe disease, a severe form of acute pancreatitis. And in this severe subset of patients, they develop organ failure, a profound systemic inflammatory response. And the mechanisms which lead to this is very poorly understood. So there's a growing base of understanding or literature suggesting genetic variation as the reason. So we undertook a systematic review and meta-analysis to identify any single nucleotide polymorphisms within the tumor necrosis factor alpha gene and to elucidate whether they were associated with severe acute pancreatitis. So our following literature search, we found 7 articles reporting 5 independent SNPs. The papers listed compared severe acute pancreatitis with mild disease. And as you can see, the comparison method varied between each study as well as the significance level reported. So we undertook 2 meta-analyses, one of tumor necrosis factor 308 and one for TNF-alpha 238. For both under the dominant effect model, we weren't able to establish any statistical significance and the reported findings need to be elucidated further with larger sample sizes. Thank you for your attention. That's the end of my presentation.
Thank you very much. Any questions?
I would like to ask if
Go. Okay.
Hello?
Yep. Hi.
Hello.
Yes.
You're here. Okay. We know that there are several it could be used for polymorphism which could influence to the outcome in patient with acute pancreatitis. Can you explain why you choose this exact gene of the alpha tumor necrosis factor? What was the reason for especially for this gene?
Sure. So the reason why we focused on tumor necrosis factor alpha is it's one of the most, it's one of the earliest mediators.
There's something wrong with connection.
It's one of the earliest mediators for the acute inflammatory process in acute pancreatitis. And TNF-alpha is the most commonly studied polymorphism. So that's also part of the reason why we wanted to look at it. But also more in terms of relevance, they're using a lot of anti-TNF-alpha agents now in big clinical trials to see whether they're useful in severe acute pancreatitis patients. So really understanding whether there's a genetic predisposition in this gene may help us understand why some patients get more severe disease.
Okay. Okay, thank you. Thank you.
Okay. We go with the last presentation for this session, endocrine and exocrine insufficiency after 2 years follow-up of acute pancreatitis, preliminary results of Goulash Plus study.
Dear audience, in my presentation, I would like to show you the rate of endocrine and exocrine insufficiency after acute pancreatitis, which are preliminary data of the Goulash Plus trial. My name is Alexandra Mikó, and I am a gastroenterology specialist from Hungary. Diabetes mellitus and exocrine insufficiency is often detected after AP. Our aim is to analyze the rate of diabetes and PAE after AP in the patients of the Goulash Plus clinical trial. Oral glucose tolerance test and fecal elastase tests were performed. Due to the shortness of time, I can only present the results of the first year follow-up. Newly diagnosed diabetes indicated by red color was 25% in the CP and 16% in the non-CP group. Grouping the patients based on the severity of the AP, likely a higher rate of newly diabetes could be shown in the severe than the mild AP group. When grouping patients based on the number of recurrent acute pancreatitis, no difference was seen between the groups. PAI was newly diagnosed in 44% in the pre-CP group and in 10% in the non-CP group. When non-CP patients were grouped based on the severity of AP, no difference was seen, but grouping them based on the number of the RAPs, the rate of PAI was likely higher in the patients who suffered from 2 or more RAP. So in summary, carbohydrate metabolism disorder seemed to be developed in moderate and severe AP and is not related to RAP. It seems that the number of RAP increases the endocrine insufficiency, while severity of AP had no effect on it during 1 year follow-up. On my poster, you can see the data of the second year as well. Thank you for your attention.
Thank you very much.
Thank you very much for a very nice presentation. If we have time, I would like to ask a question. May I?
Yes.
I am the substitute for Alexandra Miko. I'm her student.
Okay, you performed very large investigation, and I would like to ask you, did the extent of the pancreatic necrosis, I mean the size of the how injured pancreatic gland, has influenced shape into the development of the diabetes mellitus and enzyme insufficiency? Thank you.
We only grouped the patients by severity. So the severe group may contain the necrotizing pancreatitis, but we didn't do this exact comparison.
What factors beside could influence to the development of these complications?
We grouped the patients based on the number of reps, the severity by Atlanta classification, and yeah, that's it. So we kind of want to see if exocrine and endocrine insufficiency, if those develop with the duration of the chronic pancreatitis or the recurrence of the acute pancreatitis.
Okay, very, very interesting topic. Thank you. Thank you for nice presentation.
We end with all presentation for this session. There was very interesting results in this presentation, and we can close this session and continue with the Congress.
Thank you, Stefan. Very nice was to meet you and to meet each
Also,
yeah, thank you very much. I got very nice experience. Thank you.
See you soon.